Good morning, doctors. Today we are on a 24th day of reading Oxford Handbook of General Practice. I am Dr. Sesha, your study buddy, and we are preparing together for MRCGP International AKT exam. Today we are at page number 500, chapter 14, Musculoskeletal Problems, Vasculitis. Let's start reading. Characterized by inflammation within or around the blood vessels plus or minus necrosis. Severity depends on the size and site of the vessels affected. Systemic vasculitis can be life-threatening. Causes are idiopathic 50% of the cases, connective tissue disorders in association with rheumatoid arthritis SLE, infections like rheumatic fever, infective endocarditis and Lyme's disease, drugs, NSAIDs and antibiotics, neoplasia, lymphoma and leukemia. Presentation. Vasculitis can be variable, may be confined to the skin or systemic involving the joints, the kidneys, the lungs, the gut, and nervous system. Skin signs. There will be a palpable purpura, often painful, usually on the lower legs and buttocks. Systemic effects. Fever, night sweats, malaise, weight loss, myalgia, and arthralgia may occur in all types of vasculitis. Conditions. Many are rare vasculitic conditions. Erythema nodosum. Page 568. We will read that about that there. Henoch-Schönlein purpura. More common in children than in adults. Males more than females. It presents with a purpuric rash over the buttocks, anti-extensor surfaces. Platelet count is normal. Often follows a respiratory tract infection. Other features are urticaria, nephritis, joint pains, abdominal pain, may mimic an acute abdomen. Refer to pediatrics for confirmation of diagnosis. Most recover fully without treatment or over few months. Polyarteritis nodosa, PAN. Uncommon in the UK. Males to female ratio is 4:1. Peak incidence in the middle age. Multisystem necrotizing vasculitis. Aneurysms of the medium-sized arteries. Presence with tender subcutaneous nodules along the line of the arteries. Coronary arteries. Raised BP. Mononeuritis multiplex. Renal failure. GI symptoms, sometimes associated with hepatitis B. Refer to rheumatology for angiography to confirm the diagnosis or evidence of advice on management. Treatment is with control of high BP, high dose steroids and cyclophosphamide. Eosinophilic granulomatosis with polyangiitis, formerly called Churg-Strauss syndrome. Associated with asthma, affects the coronary, pulmonary, cerebral, splanchnic circulations. So this has an association with asthma and also affects the coronary, pulmonary, cerebral and splanchnic circulations. Skin manifestations and mononeuritis multiplex can also occur. Diagnosis based on clinical features and biopsy. Refer for specialist treatment with high-dose prednisolone plus cyclophosphamide. Avoid leukotriene receptor agonist drugs for control of asthma as it may worsen the symptoms in these patients. So, eosinophilic granulomatosis with polyangiitis. Avoid LTRS. Prednisolone and cyclophosphamide treatment. Granulomatosis with polyangiitis. This is vaginous granulomatosis. Granulomatous vasculitis. Any organ can be involved. Symptoms and signs relate to those affected. Mouth ulcers, nasal ulceration, epistaxis, rhinitis, otitis media, cranial nerve lesions, lung symptoms, shadows on the X-ray, raised BP, eye signs in 50% of the cases. Often long prodrome of limited granulomatosis with polyangiitis, causing nasal stuffiness, headache, hearing difficulties and nosebleeds. Limited granulomatosis with polyangiitis leading to nasal stuffiness, headaches, hearing difficulties and nosebleeds. Management. Refer to rheumatology or general medicine for investigation. ANCA helps diagnostically in disease monitoring. Treatment is with high-dose steroids, methotrexate, mycophentyl mofetil and cyclophosphamide. Again, these are immunosuppressive drugs, steroids, methotrexate, mycophenolate and cyclophosphamide. Kawasaki's disease. Kawasaki disease predominantly affects the children less than 5 years of age and has unknown cause. Diagnosis. The disease with similar presentations have been excluded and more than 5 of the following are present. So, fever for more than 5 days, bilateral conjunctivitis, polymorphous rash, changes in the lips or mouth, dry, red or cracked lips, strawberry tongue, diffuse redness of the mucosa, and changes in the extremities, reddening of the palms and soles, edema of the hands and feet, peeling of the skin of the hands, feet or groin. Cervical lymphadenopathy more than 15 millimeters diameter, usually single and painful. Increased suspicion if poor response to antipyretics. So more than 5 days, fever, bilateral conjunctivitis, polymorphous rash, changes in the lips like swelling of the lips, redness, erythema, cracked lips, swelling of the tongue, again strawberry tongue, diffuse redness, and then changes in the extremities. There is reddening and edema of the palms and soles and groin, and there is lymphadenopathy. Suspicion if poor response to antipyretics. If you suspect, refer to urgent pediatric assessment. Early treatment less than 10 days after onset with IV immunoglobulin and aspirin decrease the incidence of severity of aneurysm formation as well as giving symptom relief. So, Kawasaki's disease leads to coronary artery aneurysms. That's why you have to refer early for treatment to pediatrics and 10 days course with IV immunoglobulin and aspirin, high dose aspirin. Complications: coronary arteritis with formation of aneurysms or accelerated atherosclerosis. Tiredness and chronic fatigue syndrome. Tired all the time. Fatigue is common. 1 in 400 sustained episodes of fatigue generate a GP consultation. GPs see 30 patients per year whose main complaint is fatigue and may be a secondary symptoms to many others. Secondary 2% consultations result in secondary care referral. Almost any disease process can cause tiredness, whether physical or psychological. Physical causes account for 9% of the cases. 75% have symptoms of emotional distress. Assessment: onset and duration of fatigue. Short history, abrupt onset suggests a post-viral or diabetes. Pattern of fatigue. On exertion, relieved by rest, suggests organic cause. Worst in the morning and never goes, suggests a depression. Associated symptoms. Breathlessness, weight loss, anorexia, suggest organic cause. Chronic pain may suggest fatigue, may cause fatigue. Sleep patterns. Early morning awakening or unrefreshing sleep suggests depression. Snoring, pauses of breathing in sleep, and daytime sleepiness suggest sleep apnea. Psychiatric history. Symptoms of depression, anxiety, or stress. Alcohol and medication, including OTC and illicit drugs. Patient's worries. What does the patient think is wrong? Examination usually normal. Common organic causes of fatigue in general practice are anemia, infections, EBV, CMV, hepatitis, diabetes, hypo or hyperthyroidism, perimenopausal age group, asthma, carcinomatosis, and sleep apnea. Investigation. If sustained fatigue with no obvious cause, check the urine. Urine dipstick for protein, blood, and glucose, and blood. FBC. All children should have FBC or blood film checked on presentation with fatigue. ESR, CRP and EGFR, urea electrolytes, EGFR, LFTs and calcium, thyroid function test, random blood glucose, anti-endomycin antibody test to exclude celiac, creatinine kinase, consider Lyme's disease titers. So other causes you have to consider: calcium levels, again ESR, CRP, urine electrolytes, creatinine, uh, EGFR, LFTs, calcium, thyroid function test, random glucose, endomycin antibodies for celiac, and Lyme's disease titers. In addition, check serum ferritin if the patient is a child or young person. Do not check ferritin in adults unless FBC suggests iron deficiency. For a child, you can check ferritin for fatigue. Use clinical judgment to decide on additional tests to exclude other diagnoses. Example, serological testing if it is suggestive of infection. Management. Treat the organic causes. In most cases, no physical causes found. Reassure. Explaining the relationship of psychological and emotional factors to fatigue can help patients deal with symptoms. If last more than 6 to 12 weeks, symptoms or signs of depression, consider a trial of antidepressants. Example, sertraline 50 mg OD. So if your fatigue is lasting more than 6 to 12 weeks and symptoms and signs of depression are there, consider a trial of antidepressants. Example, sertraline for 50 mg OD. Chronic fatigue syndrome, a debilitating and distressing condition. Prevalence is 0.2 to 2.6, which is again more in females to males. Females to male ratio 3:2. Cause is unknown. Although viral infections 10% after EBV infection, immunizations, chemical toxins, organophosphates, chemotherapy drugs have all been implicated in chronic fatigue syndrome. Fatigue must have been present for more than 4 months for adults and more than 3 months for children and young people for diagnosis of CFS to be made. Clinical features: unexplained, persistent or recurrent fatigue of new or definite onset, not explained by other conditions and resulting in decreased activity, often starting 1 to 2 days after mental or physical exertion and lasting more than 24 hours, and more than one of the following. Often starting 1 to 2 days after mental physical exertion and lasting more than 24 hours, and more than one of the following should be present: general malaise, dizziness, nausea, palpitations without cardiac dysfunction, cognitive dysfunction, impaired concentration or memory, tender cervical or axillary lymph nodes without enlargement. Physical mental exertion makes the symptoms worse. Headaches of new type, pattern or severity. Multi-site muscle or joint pain without inflammation, sore throat, difficulty with sleeping. Additional symptoms: must have predated fatigue. Symptoms will fluctuate or change in nature over time, include postural dizziness, vertigo, altered temperature sensation, paresthesia, sensitivity to light or sound, palpitations, IBS, food intolerance, fibromyalgia, feelings of dyspnea, mood swings, panic attacks, and depression. Infection or immunization, drugs, caffeine, alcohol, and stress cause setbacks in the management of chronic fatigue syndrome. Red flag symptoms that suggest other diagnoses other than chronic fatigue syndrome are significant weight loss, Localizing or focal neurological signs. Signs and symptoms of inflammatory arthritis or connective tissue disease. Signs or symptoms of cardiorespiratory disease. Sleep apnea. Clinically significant lymphadenopathy is there. Reconsider the diagnosis if none of the following are present. That is cognitive difficulties, chronic pain, post-exertional fatigue or malaise, sleep disturbance. So if these are not present, then you have to reconsider the diagnosis of fibromyalgia. If any of these are present, then you have to reconsider the diagnosis of chronic fatigue syndrome. Management. Provide support and reassurance. Explanation. Information plus self-help groups. Avoid exacerbating factors like caffeine and alcohol. Advise graded exercise, regular, limited rest periods. Example, 30 minutes, 4 to 5 days. Treat the symptoms. Example, amitriptyline, 10 to 50 milligrams nocturne to help in sleep and relieve the headache and neuropathic pain. SSRS for depression. Refer the adults if severe symptoms are there. And symptoms persist more than 6 months. Specialist treatments include CBT and rehabilitation programs. Prognosis. Variable. 55% of adults have symptoms more than 6 months. Risk increases if 3 times if his history of anxiety or depression. Prognosis in children is better. Children presenting with sustained fatigue of any duration with no obvious cause should always be referred for pediatric review. Miscellaneous conditions. Neuropathic arthritis. Charcot's disease is a rapidly progressive degenerative joint which lacks the position sense and protective pain sensation. Upper limb disease is usually associated with syringomyelia. If you have an upper limb Charcot's, it's associated with syringomyelia. Lower limb disease is usually associated with diabetic neuropathy or cauda lesions. Joint may be very deformed but is usually painless. They treat the underlying condition like diabetes. The joint cannot recover but refer to orthopedics for advice on stabilization. Fibromyalgia. Painful non-articular condition of unknown cause predominantly involving the muscles. Fibromyalgia is common and often results in significant disability. Peak age is 40 to 50 years. 90% of them are female. Diagnostic criteria. History of a widespread pain defined as pain on both left and right sides above and below the waist. Widespread pain defined as pain on both right and left sides above and below the waist together with an axial skeletal pain, example the neck pain, neck or back pain, in combination with pain in more than 11 out of the 18 tender sites on digital palpation. So there will be pain in more than 11 out of the tender sites on digital palpation on examination. So this is the neck, cervical area, then this is interscapular area, then this is supraclavicular area and clavicular area, again in the cubital fossa, again in the gluteal region, again just at the origin of the thighs, again this is just above the knee joint. So insertion of the nuchal muscles into the occiput. This is point number 1 here, nuchal muscles into the occiput at the base of the skull. Upper border of the trapezius mid portion, muscle attachments to the upper medial border of the scapula, anterior aspects of the C5 C7 intertransverse spaces, second rib space 3 cm lateral to the sternal border, muscle attachments to the lateral epicondyle at the elbow, upper outer quadrant of the gluteus muscles, muscle attachments just posterior to the greater trochanter, Medial fat part of the knee just approximal to the joint line. These are the points of tenderness. 9 points. Tender points for diagnosis of fibromyalgia. Among these, pain in 11 out of the 18 tender points. That means bilateral the points will be there. So 11 out of the 18 points there should be pain. Other clinical features are of fibromyalgia. Clinical findings: unremarkable pain is worse by stress, cold or activity associated with generalized morning stiffness. Analgesics, NSAIDs and local physical treatments are ineffective and may worsen the symptoms. Sleep patterns are poor. Patients tend to wake exhausted and complain of poor concentration. Anxiety, depression scores are high. Associated symptoms include unexplained headache, paresthesia of the hands and feet, and urinary frequency and abdominal symptoms. Unexplained headache, paresthesia of the hands or feet, urinary frequency and abdominal symptoms. Investigations: exclude other causes of pain and fatigue. Example: hypothyroidism, SLE, Sjogren's, psoriatic arthritis, inflammatory myopathy, hyperthyroidism and osteomalacia. So other causes of pain and fatigue you have to exclude, which could be hypothyroidism, SLE, connective tissue disorder, Sjogren's, psoriatic arthritis, inflammatory myopathy, hyperparathyroidism or osteomalacia. Check for, so you have for excluding these causes, you have to check for FBC, ESR, thyroid function test, urea electrolytes, EGFR, calcium, creatinine kinase, phosphate, ANA, RF and immunoglobulins. Management: multidisciplinary approach is useful. Be supportive. Reassurance that there is no serious pathology. Explanation and information are vital. Low dose amitriptyline, this is for fibromyalgia. Low dose amitriptyline 25 to 75 milligrams nocte may help with sleep or pain. SSRIs example sertraline 25 to 50 mg OD may help in anxiety, depression or sleep. Stop if no improvement after a 1 month trial. Graded exercise regimens improve the pain, lethargy or mood and malaise. Counseling, learning, coping strategies, CBT can be beneficial. Some patients benefit from injection of hyperalgesic trigger points with steroid or acupuncture to trigger points. So this is an important point. Some patients benefit from injection of the hyperalgesic points with steroid or acupuncture to trigger points. Hypermobility. Child or young adults with lax joints, feel less than 50% are symptomatic. Those have symptoms present with recurrent joint pains, mainly affecting the knees. Other symptoms include joint effusion, dislocation, ligamentous injuries, low back pain, and premature osteoarthritis. The condition is benign and the joints become stiffer with age. Treatment, when is needed, is with physiotherapy, rarely associated with congenital disorders like Ehlers-Danlos syndrome. So hypermobility of the joint can be associated with Ehlers-Danlos syndromes. Tietze syndrome, idiopathic costochondritis. Pain is enhanced by motion, coughing or sneezing. Second rib is the most commonly affected. Examination: marked localized tenderness and differential diagnosis can be muscular sprain, rarely inflammatory chest wall enthesitis, osteitis secondary to spondyloarthropathy. So this can be the differential diagnosis. There will be marked localized tenderness in the second rib. Management: explanation and reassurance that nothing serious is happening. Simple OTC analgesia, example ibuprofen 400 milligrams TDS. If pain persists, local steroid or bupivacaine injections can be helpful. If not settling, consider referral to rheumatology. Further information: European League Against Rheumatism, check that out. So our next chapter for discussion is neurology. Page number 508. Topic is reflexes and muscle power. Reflexes. Reflexes are automatic responses. The reflex arc goes from the stimulus via the sensory nerve to the spinal cord and then back along a motor nerve to cause muscle contraction without brain involvement. Key reflexes. Record whether absent, present or reinforcement, normal or brisk plus clonus. Present with reinforcement, normal or brisk plus clonus. Absent or decreased reflexes implies a breach in the reflex arc at the sensory nerve root or root. uh, Example: neuropathy, spondylitis, anterior horn cell, motor neuron disease or polio, motor nerve root, neuropathy or spondylosis, nerve endings, myasthenia gravis, or muscle plus myopathy. Muscle, example: myopathy. So increase in reflexes implies a lack of higher control, example: an upper motor neuron lesion, example: post-stroke. Clonus, rhythmic involuntary muscle contraction due to abrupt tendon stretching, like dorsiflexion of the ankle associated with upper motor neuron lesion. Reinforcement, method of accentuated reflexes. If a reflex seems to be absent, ask the patient to clench their teeth to reinforce the upper limb reflexes or clench their hands and pull in opposite directions to accentuate lower limb reflexes. Okay, this is reinforcement. This effect only lasts more than 1 second, so ask the patient to perform the maneuver simultaneously with a tap on the tendon hammer. Tap with the tendon hammer. Okay, testing for muscle power. Quick screening test for muscle power. Shoulder abduction. So this is testing for muscle power, not reflexes. So we are just checking the nerve roots. Shoulder abduction is caused by the deltoid C5 C6. Adduction is caused by triceps C6 C8. Elbow flexion is caused by the biceps C5 C6. Extension is caused by the triceps C7 C8. But these are the C7 C8 fibers of triceps. Wrist flexion is caused by the flexor distorum profundus C7 C8. Extension is caused by again triceps C5 C6 C7. Fingers, sorry, not extension is not called extensor distorum profundus. Fingers, flexion is caused by ulnar nerve C8. Extension is caused by ulnar nerve C7. Abduction is caused by T1. Again lower limb. Hip, flexion is caused by the gluteus muscles L1 to L3. Extension is also caused by the gluteus muscles L4, L5, S1. Knee, flexion is caused by L5, S1 nerve root. Extension is caused by L3, L4 nerve root. Ankle, dorsiflexion by L4, L5, plantar flexion by S1, S2. Toes, extensors L5, S1, flexors S2. Testing proximal muscle power by asking the patient sit from lying, pull towards him or herself, or raising from squatting. Key reflexes and nerve roots involved. Jaw reflex. Ask the patient to let his mouth open slightly. Place a finger on the chin. Tap the finger with a tendon hammer. Accept expected result: contraction of the masseters and closure of the mouth. Nerve roots. Fifth cranial nerve. Gag reflex. Touch the back of the patient's pharynx on each side with a spatula. If absent, ask the patient whether he can feel the spatula. If he can, then tent nerve palsy. Contraction of the soft palate, gag reflex. Ninth and 10th cranial nerve. Biceps. Tap a finger placed on the biceps tendon by letting the tendon hammer fall on it. Contraction of the biceps plus elbow flexion. C5, C6. Supinator. Tap the lower end of the radius just above the wrist with the tendon hammer. Contraction of the brachioradialis and elbow flexion. C5, C6. Triceps. Support the elbow in flexion with one hand and tap the triceps tendon with a tendon hammer on the other hand. Contraction of the triceps plus elbow extension. C7, C8. Knee. Support the knees so relaxed and bent. Let the tendon hammer fall onto the infrapatellar tendon. Contraction of the quadriceps plus extension of the knee. L3, L4. Ankle reflex. Externally rotate the thigh and flex the knee. Let the tendon hammer fall onto the axialis tendon. Contraction of the gastrocnemius plus plantar flexion of the ankle. S1. Abdominal muscles. Lightly stroke the abdominal wall diagonally towards the umbilicus in each 4 abdominal quadrants. Abdominal wall contractions, when absent, can be normal or indicate upper motor neuron or lower motor neuron lesions. T7 to T12. Cremasteric reflex. Male patients only. Pre-warm the patient. Stroke the superior and medial aspect of the thigh in a downward direction. Contraction of the cremasteric muscle raising the scrotum and testis on the side stroke, absent in UMN and LMN lesions. So absent is not normal. Absent in upper motor neuron lesions and lower motor neuron lesions. L1. Anal reflex. Scratch the perianal skin. Reflex contraction of the external sphincter, absent in upper motor neuron and lower motor neuron lesions. S4, S5. Plantar. Pre-warn the patient. Run a blunt object up the lateral side of the sole of the foot, curving medially before the NTP joints. Flexion of the big toe, if more than 1 year old. Extension implies an upper motor neuron lesion. 510. Cranial nerve lesions. Cranial nerves may be disrupted at any point from the nerve nucleus to the brainstem to the point of innervation. Table 15.3 lists clinical tests for each nerve. Figure 15.1 maps cutaneous innervation of the head and neck. Think systematically about the level of lesion. Potential sites could be the muscle, the neuromuscular junction, along the course of the nerve outside the brainstem, within the brainstem. Any cranial nerve may be affected by diabetes, multiple sclerosis, tumors, sarcoid, vasculitis, or syphilis, and more than one nerve may be affected by lesion. Refer according to the case, usually to ENT, ophthalmology, or neurology. Cranial nerve lesions and their causes. First, olfactory. Clinical test is smell. Test is nostrils for ability to differentiate between different smells. Causes are trauma, frontal lobe tumor, and meningitis. 2. Optic nerve. Acuity. Snellen's chart. Visual fields. Compare with your own visual fields by standing directly in front of the patient with your head at the same level as theirs. Monoocular blindness. Lesion in one eye or the optic nerve, like multiple sclerosis, giant cell arteriitis, can lead to damage to the one unilateral nerve. So, optic nerve. First is visual acuity, visual fields, and pupils. The size and shape reaction to light and accommodation. Ophthalmoscopy. Darken the room, view the optic disc. Pale and swollen. Follow each vessel outwards to view each quadrant. Track outwards to check the lens and cornea. Bitemporal hemianopia, optic chiasmal compression, example pituitary adenoma or a craniopharyngioma, internal carotid artery aneurysm can lead to bitemporal hemianopia. Homonymous hemianopia affects half of the visual field on one side on a side opposite to the lesion caused by lesion beyond the optic chiasma, either in stroke, abscess, or tumor. Cranial nerve 3. Ptosis, a large pupil, looks eye down and outwards. The eye looks down and outwards, downward and outward facing eye, ptosis, and a large pupil. And diplopia from a third nerve lesion may cause nystagmus. So, because it supplies the external muscles, so eye looks down and outwards. Diabetes, giant cell arteriitis, causes are diabetes, giant cell arteriitis, syphilis, posterior communicating artery aneurysm, idiopathic. If a pupil is normal in size, results from diabetes or other vascular cause. Cranial nerve 4. This is lateral LR6 and SO4. So, superior oblique is supplied by the cranial nerve 4 or trochlear nerve. So, diplopia on looking down and in may compensate by tilting the head. So, there will be diplopia on looking down and in while walking down the stairs, etc. So, rare isolation may occur as a result of trauma to the orbit. Cranial nerve 5 or trigeminal nerve. Motor component supplies to the mandibular nerve. Opening of the mouth, the jaw deviates to the side of the lesion. In case of there is a lesion, the jaw is deviated to the side of the lesion. Sensory. Corneal reflex is lost first. Check all three divisions. Sensory, trigeminal neuralgia, causes are trigeminal neuralgia. Herpes zoster, nasopharyngeal carcinoma. Motor is bulbar palsy and acoustic neuroma. So in acoustic neuroma, there is another component, that is loss of corneal reflex. Cranial nerve 6. Horizontal diplopia on looking outwards. That is because it is lateral rectus palsy. So lateral gaze palsy will be there. That's why there will be horizontal diplopia on looking outwards. Multiple sclerosis, pontine cerebrovascular accident, or increase in intracranial pressure can lead to cranial nerve 6 palsy. Cranial nerve 7 or facial palsy causes facial weakness and droop, asks to raise the eyebrows and show the teeth and puff out the cheeks. Element lesion, all on one side of the face affected. Upper motor neuron, lower 2/3 of the face only is affected. Causes are lower motor neuron lesions are Bell's palsy, polio, otitis media, skull fracture, cerebellopontine angle tumor, parotid tumor, herpes zoster, Ramsay-Hunt syndrome. Low motor neuron lesions. Upper motor neuron lesions are stroke and tumor. Eighth nerve palsy, vestibulo-auditory nerve palsy, vestibulocochlear nerve palsy. Auditory, ask the patient to repeat the number 1 in one ear while you block the other. Vestibular nerve, ask about the balance, check for nystagmus. Ask the patient to fix a gaze on the finger 1.75 meters away and check the gaze upwards and downwards and lateral and both direction. Keep the finger 30 degrees from the midline. Causes are noise-induced hearing loss. So noise is a cause for auditory nerve. Paget's disease because of remodeling of the skull bones. Meniere's disease. Herpes zoster, acoustic neuroma, brainstem. lesions, CVA and drugs. So acoustic neuroma will affect cranial nerve 7, cranial nerve 8. No, acoustic neuroma will affect cranial nerve 8 and cranial nerve 5. Cranial nerve 8 and cranial nerve 5. Herpes zoster will affect the cranial nerve 7 and cranial nerve 8. CVA and drugs like furosemide will affect the hearing by nerve damage. Cranial nerve 9 and 10 causes the gag reflex, the palate moves and normal side saying ah. Trauma, brainstem lesions, neck tumors. Cranial nerve 11. Trapezius, shrug the shoulders against resistance. Sternomastoid, turn the head to the right or left against resistance. Cranial nerve 9. Trapezius, shrug the shoulders against resistance. Sternocleidomastoid, turn the head to the right or left against resistance. Rare. Palsy is rare. Polio, syringomyelia, tumors near the jugular foramen, stroke or bulbar palsy. Polio, trauma, TB. Cranial nerve 12. The tongue deviates to the side of the lesion. Trauma, brainstem lesions and neck tumors. So there are two cranial nerves, that is one is 9 and 10. The cranial nerve 5 and mandibular division causes jaw, supplies muscle for the movement of the jaw, and when there is a lesion the jaw deviates towards the side of the lesion. Again, cranial nerve 12, the tongue, supplies hypoglossal nerve supplying the tongue. Whenever there is a lesion in the hypoglossal nerve, the tongue also deviates to the side of the lesion. Whereas in the gag reflex, cranial nerve 9 and 10, when gag reflex, when there is palsy on one side, the palate moves to the normal side and not to the affected side. So the palate is a pull function, whereas the jaw and tongue is the push function. So these are the dermatomal distribution of the ophthalmic division of the trigeminal nerve. This is the distribution. This is C2. This is facial and vagus nerve. This is the mandibular nerve division. This is the maxillary division of the trigeminal nerve. This is C2 and C3. This is C3, this is C4, this is C5, this is C3 and C4. Cutaneous innervation of the head and neck. Page number 512, neuropathies. Dermatomes and peripheral nerve distribution has already been given in figure and figure 15.2 and 15.3. Mononeuropathy. The lesions of individual nerves, including the cranial nerves, causes are trauma, compression, diabetes, leprosy. If more than one peripheral nerve is involved, then the term mononeuritis multiplex is used. Causes could be diabetes, sarcoid, cancer, PAN, polyarteritis nodosa, and amyloid and leprosy. So in polyarteritis nodosa, the blood vessels supplying uh, the major blood vessels supplying medium-sized blood vessels are affected. So whenever a blood vessel supplying this nerve is affected by PAN, then it will cause mononeuritis multiplex. Amyloid or leprosy are other causes. Common mononeuritis tables in 15.4, we will check that. Bell's palsy Is a facial palsy without other signs. Unknown cause, possibly viral. Peak age incidence is 10 to 40 years and female and male same prevalence. Lifetime incidence 1 in 65. Affects the left side and right side of the face equally often. Usually sudden onset, may be preceded by pain around the ear. Other possible symptoms are facial numbness and decrease in tolerance, disturbed taste on the anterior part of the tongue. Facial numbness, decrease in noise tolerance, disturbed taste on the anterior part of the tongue. Management: 70% recover completely, 13% have a insignificant sequelae, remainder have permanent deficit. 85% improve in less than 3 weeks, so reassure them. So if 3 weeks have passed, give prednisolone. Less than 3 weeks, reassure. Initially give them prednisolone 25 milligrams by BD for 10 days if less than 72 hours after onset of symptoms. Protect the eye and tape the lid shut and pad at night. Glasses in the day plus artificial tears if drying. Refer. If recovery is not starting after 3 weeks, for tarsorrhaphy if complete or long-standing palsy, if unacceptable cosmetic result may benefit from plastic surgery. Ramsay-Hunt syndrome is herpes zoster oticus. Severe pain in the ear precedes the vagal nerve palsy. Zoster vesicles appear around the ear in the external ear canal or on the soft palate in the tonsillar fossa, often accompanied by deafness and vertigo, which are very slow to resolve and may result in permanent deficit. Pain usually abates after 48 hours, but post-herpetic neuralgia can be a problem if detected less than 24 hours after the rash appears. Treatment with antivirals. Acyclovir 800 milligrams 5 times a day for a week may be effective. Motan's metatarsalgia, we have already read in page 472. Autonomic neuropathy. Postural hypotension, dizziness or syncope standing or after exercise or large meal, impotence, inability to sweat, vomiting, dysphagia, diarrhea, constipation, urinary retention or incontinence. Horner syndrome. Check the BP in lying and standing, and a postural drop of more than 30 by 15 is abnormal. Causes could be primary autonomic failure. No known cause, occurs alone as a part of multisystem atrophy. Typically middle-aged elderly men. Onset is insidious. Survival rarely more than 10 years after diagnosis. Aging. 25% more than 74 years have a postural hypotension. Review the medication. Discourage prolonged bed rest. Often associated with disordered thermoregulation, making elderly people prone to hypothermia. Exclude other disorders, example diabetes, multisystem atrophy, drugs, before putting down to aging alone. So you have to exclude other causes like diabetes, multisystem atrophy and drugs. Drugs that cause postural hypertension, common culprits. Autonomic neuropathy, antihypertensive like thiazides and diuretics, overdiuresis and levodopa, tricyclic antidepressants, phenothiazines and benzodiazepines. These are the drugs that will cause postural hypotension. Polyneuropathies may be part of more generalized polyneuropathy, example diabetes, Guillain-Barré syndrome or alcoholic or nutritional neuropathy. Other causes: craniopharyngioma, vascular lesions, spinal cord lesions, stapes dorsalis, Chagas disease, HIV and familial dysautonomia. Management: treatment the underlying cause. Advise patients to stand slowly and raise the head above the bed at night. Eat little and often and decrease the carbohydrate and alcohol intake. Fludrocortisone 0.1 milligrams per day, increasing PRN, may help those severely affected. Refer if diagnosis is unclear or simple measures are ineffective. Polyneuropathy, page number 516. This is a table showing common mononeuropathies. So this was page number 513. We will stop here for today, and then tomorrow we will continue from common mononeuropathies table, page number 513. Thank you. Have a good day.